a long time ago. Yeah? So Baker cyst is a subset of popliteal cyst. There are many kinds of popliteal cyst. Popliteal cyst just describes cyst which arises in the popliteal region. Baker cyst is one such cyst. Okay? So very often you get elderly lady, will get a ruptured Baker cyst with fullness of the popliteal region. So again, in the exams you have to mention on patient lying prone, there is no fullness. Although you mentioned it earlier on, but in the exams, when you lying patient prone, mention it again, reinforce it. Like I say, examiners are usually lazy, they probably forgotten what you say. So when you reinforce things, they feel, oh, this guy is thinking, so he wants to lie. Okay. So when patient is lying prone, there is no fullness over the popliteal region, no dilated veins, no abnormalities noted. I would like to proceed with dial test is not your level. Dial test is to check for PLC complex, posterolateral contact complex. It's not your level, I don't have to know that. But grinding test you must know. There's another alternative. So how a grinding test is done is, okay. So the Epplis describe this test. So we call the test after him. It's called Epplis grinding test and Epplis distraction test. So you stabilize the gaze. So somebody must look at the patient's face like that. So you press and you compress, you externally rotate. When you do this, you're compressing the medial meniscus. So if patient is painful, dia akan terkejut lah, dia akan kata is painful lah. So that's the test is positive for a medial meniscus injury. So if you this is internally rotate. When you internally rotate, the tibia will rotate at the lateral meniscus. So if it's painful or you hear a click, then it's positive for a lateral meniscus injury. And then at the same time, when you hold your femur, you distract, dia akan kurang sakit. So when you distract, there's less pressure on the meniscus. But this usually is not specific for either medial or lateral meniscus. Okay? And finally, you check the pulses lah. This is best done when the patient is supine. Okay? Supine. Right. So any questions on the knee examination? That is a complete knee examination. Yes, yes, very well. Yes, yes. That is done when the patient is extended lah. Fluid shift test and a bulge test, but like that. Yeah, it's a good point. You have to do that when the patient is extended. If there is fullness, if there's no fullness, don't rely. Alright, okay. We still got hand examination to go. Any questions here? Alright, okay. So we thank Farid dengan Arif lah. So now we go on to hand examination. Boleh ke? Tu kenal dah? Okay. So hand examination again, median nerve, kanan nerve and median nerve. So kita nak pilih Arif ke kita nak pilih orang lain? Orang lain lah kot. Kan? So let's choose one of the girls. Boleh? Examine by another girl. Boleh ke? Usually carpal tunnel syndrome is in a female. So kita betul-betul ikut macam patient lah. Okay. So Farid and Arif, you all can choose lah who wants to be the volunteer. One of your friends lah, the girls lah. Choose a volunteer and choose a examiner. You want me?
Dayang.
Okay. So Dayang is the patient ke? Dayang is the examiner?
Examiner.
So she's the candidate lah, she's the student right? Okay, so the patient would be?
Shena.
Okay. Yeah, man, it's good to learn now. Yeah. Okay. So you sit down. So this is the history again, right? So don't have to time, but just see how it goes, right? So again, guys, you all have to practice this at home. Write down the script, how far the script, go and practice with your friends. That's the only way, no other ways. Okay. So this is a comfortable looking patient, right? The history is this is an elderly lady who has difficulty to sew clothes for children. She has night pain and she has to wiggle her fingers to relieve her pain. Her symptoms are confined to the right hand. So your question is, please examine this patient's right hand. Okay.
On inspection, she is lying over the couch of the bed.
She is lying.
Sorry,
You are lying.
she's sitting.
How dare you?
Over the end of the bed.
So So always be prepared for kejutan lah. Usually kejutan are nasty lah. You are doing well. Your introduction was okay. Don't forget to always protect patient's modesty. Also expose the patient after screening lah. So sometimes for the hand examination, examiners will ask to expose till the shoulder. So you still have to mention that ideally I would like to expose patient till shoulder region. Then you actually do attempt, okay, makcik saya nak, makcik pakai baju kat dalam, boleh tak kita minta selitkan baju sikit. Then I go, no, it's okay, this is comfortable, please proceed. Yeah, okay. So okay, please proceed.
Should I comfortable like you? So let us proceed with the hand examination. Okay.
Okay, so always the trick here is, in hand examination, you will always get a pillow by the side. Usually patient akan pakai baju yang colour-colour lah. So when you ask them to put their hand on the pillow, it becomes obvious the deformity if there is. Yeah? Okay. So it's okay, you don't have to expose it. You just kita examine tangan saja. Seperti itu guys ni lah.
So on inspection, I would like to see if there are any of the skin changes, any ulcer, any inflammation changes, any muscle wasting, or maybe
Okay, you can apply skin, muscle, bones and joints.
so any muscle wasting over the working out the muscles, and then any wasting over the intrinsic muscles, any deformity over the wrist, over the MCT of the epidacty joints, palpation.
Okay, so belum lagi, always compare the other side. Yeah? And then check the dorsal of the hand lah. You mentioned the palmar as well. The dorsal of the hand. So the other thing is sometimes patient wears watch and rings. You have to ask them to remove. Very sneaky examiners will have some lesions underneath the watch, especially kalau jam tangan besar macam tu kan. So you ask patient to remove. So that will be a complete examination. Dengan jewelry pakai. It's okay, you don't have to remove lah, I'm just telling that. Okay, so you finish your loop. Then.
So palpation, look for temperature changes of the joints.
Sometimes there will be chairs at the side. You can ask permission to sit. Ask permission lah, jangan ambil duduk. Examiner pun diri takkan student nak duduk pun. So you can ask for examination, then makes you more comfortable. Again, I'm emphasizing, when you practice this again and again at home, it becomes very smooth lah. You can do it 10 times a day. InsyaAllah by the time the exam comes, it's just reflex. Kejut tengah malam pun bukan, okay, hand examination. So tenderness is always felt at bony prominences like PIPG, DIPG, the wrist joint. So again, ada yang sometimes the examiner are nice. They ask you to examine. Patient has a problem with the right hand, please examine her right hand. Sometimes the examiner are nice, they give general. Patient has problem with the right hand, but examine her hands, bilateral hand. Then you would always like to examine the normal hand, and then you will do that normal hand. So this examiner is a nice examiner lah. You examine the right hand. Yeah? So you're doing an okay job. You've already feel tenderness. Next you're going to your belum lagi. Range of motion. So how do you assess range of motion of the hand? Maybe you can ask one of your friends. Okay, you need somebody who can define or describe what is a normal cascade of the hand, what is a normal finger cascade. You don't have to answer both of you all. You can call one of your friends there to help you.
One of them.
Yes, ask them. Biasa yang buat tengok buku, buat these are people who want to catch them. Not the guys lah, guys dah berani dah break those lah. Okay, what is the normal finger cascade?
They like stare like this reflections of the little finger.
Okay. So normal finger cascade means when you flex the finger, they will point towards your scaphoid tubercle. Yeah? If it goes like this, sometimes you get fracture with rotation deformity. So one finger too goes away downwards. It should flex towards the scaphoid tubercle. That is one way to describe. The other way to describe is the knuckles. So the knuckles are present, or the metacarpal heads are present. Finger cascade is intact. Okay. So again, when you say things like this, they'll ask you finger cascade is intact. If you're not sure, you don't have to mention so on assessment of the range motion of the mass movement of the hand, range of motion appears to be normal. And you just keep on talking and you proceed. If you're not sure, you don't mention. But finger cascade, that's a description. Okay. So kalau trigger finger, the finger cascade is lost as well. When they open, so you ask patient to flex, open lah, genggam, buka. So when they flex, one finger is stuck or something like that, the trigger finger. They won't ask you for trigger finger for exams but if they get desperate, they may Again, like I said just now, for knee examination, classical cases for exam is ACL, PCL. But sometimes tak ada case sangat, they give you septic arthritis of the knee, ataupun rheumatoid arthritis of the hand, yang ada lower limb manifestation. So read up on all these lah. It's a very important short cases. Okay, yes, okay, please proceed. So range of motion settle. So now you will probably do so from the history, you have to pay attention that the history is very suggestive of which nerve pathology there. Yeah, it's most likely because she has to wriggle her hand. Like that's very classical of a carpal tunnel syndrome. So besides median nerve compression over the carpal tunnel, which results in carpal tunnel syndrome, anywhere else the median nerve can get compressed. Which will be yes, pronator TB syndrome 2, 3. Cervical radiculopathy or spinal in origin. So median nerve can be compressed in 3 cases: carpal tunnel, your forearm, which gives you pronator TB syndrome, or higher up, maybe cervical radiculopathy or spinal stenosis. Okay. So very often you get a carpal tunnel syndrome, but you have to show there is carpal tunnel and something syndrome. There are some tests to do that. Okay, we proceed with our special test now. Not necessarily lah. Kalau itu something that you're used to lah. So the idea is that lah. Some people say this one, ring finger and little finger pun cukup. Kalau you all finger kena nervous ni tak perlu juga. But don't have to change your finger lah. Always compare both sides. So you say for opponent's policies, which is specifically supplied by AIN, anterior anterior. There is a syndrome known as AIN syndrome. Tak payah tahu not your level lah. Okay. So the other thing Dayang was checking was, makcik cuba tolak jari ke atas ke ceiling, checking for abductor policies. Okay. Alright. Anything else? FDS on the limb index finger. FDS and okay. You stabilize the PIPA and ask her to flex. Yang keduanya, you ask the patient to, this is your FDS, superficialist. FDP is distal lah. You stabilize the PIPJ and you flex. This will be weak because you have to compare with the other side. Specifically only FDS and FDP of the index and the middle finger. Okay. Everybody clear on that? FDS and FDP of the index and middle finger. So 3 power you check in median nerve. Satu is your ATP, abductor policies, second is your opponent's policies, and third is your FDS and FDP of the middle finger and your index finger. 3 power you have to check. Okay?
So FDS will
most of the time FDS, you just ask patient to flex lah. You can do this, you can do like this, or you can just that's what we do like FDS. You don't have to fight. You have to fight. FDP you have to fight. You stabilize the PIPG. I'm just giving you a brief outline lah. It's not brief lah, quite detailed juga lah. Go back and read again then you really reinforce the thing. Balik baca tonight. Jangan simpan besok tu. By only comparing with the knowledge, you just do in isolation with the knowledge. Alright, okay, now we move on to provocative tests. Why is it called a provocative test? Because there are specific tests which provoke the patient's symptoms. There are about 5 or 6 tests for median nerve and carpal tunnel region itself. 5 or 6 tests. Dayang is going to show us all 5 or 6. No, at least she's going to try lah. You show us what you know. Single sign is not a provocative test, it's just a sign to show that the nerve is compressed there. So the nerve is compressed at the carpal tunnel. You will get distally. Sometimes you will get proximal. Not always is proximal. Most of the time but the nerve is compressed. The nerve is intact but it's compressed. So when you actually percuss at the compressed area, it becomes more obvious. It's distally. So distally pula, patient will be able to tell you, oh saya sakit kat macam ni, sakit dekat ni, 3 jari. So they can actually tell you it's along the median nerve distribution, very specific renal sign. Okay. So we're moving on to special sign today. Okay, renal sign something like this. That is a fellow or reverse fellow? That's a fellow sign. So how long do you do this? The books tell us 2 minutes, but the right way to do is you ask patient to flex and you time lah. So the reverse fellow is positive at 8 seconds. The lesser the time, the more severe it is. Kita tak adalah tunggu 2 minit sampai ni. Orang biasa pun akan lepas juga tangan ni. And you don't have 2 minutes to waste. So you just ask patient to do this and then you measure how long. So always keep your watch lah. So the students must keep the watch. The patient have to take out the watch. Yeah. This is reverse balance and this is this is balance and this is reverse balance. Okay. 1, 2, 3. Very good. The compression test is the most sensitive test for carpal tunnel. You compress and flex. The idea is to compress the carpal tunnel, so you're provoking the symptom. So again, it's the measure. Again, it's gaya je lah, you press it.
Tak nampak ada dia buat estimation.
The other provocative test, we tell you the compression is approximate. So example would be, you ask patient to flex in a supinated hand. You ask patient to flex resisted flexion in supinated hand. Because you tighten the lacertus fibrosus, which can compress the median nerve proximal here. This is all part of pointer syndrome, pointer syndrome. So kalau you compress the patient, sakit-sakit kat tangan dia, then you know the pathology is here. Usually patients like this will not get a positive Duncan's test, phalanx, reverse phalanx, semua tak dapat. They will get positive only here. So this is test number 4. Test number 5 is you ask patient to extend and semi-pronate, resisted pronation in an extended forearm. You are seeing the other part, or median nerve can be compressed along the forearm in many places. 3 is here, 1 is here, I don't really remember it now offhand. You don't have to know as well. You just have to know whether it is in carpal tunnel or not in carpal tunnel. Okay. So this is the 4th provocative test. The final provocative test is your cervical spine examination. So what cervical test would provoke a radiculopathy? It's known as the Lermite's test. Ask patient to flex and face the affected. Should feel the electric sensitivity. He knows the radiculopathy is from the neck. Okay? Boleh? Dapat confuse ke? Boleh? Okay? Special test.
Tak sekali.
Sensation is deficit over the 3.5 fingers.
Sebenarnya pusing. Tarik.
Gini. Boleh.
tunduk dulu. Dia buat flexion. Ni lemit. Flex out.
Sebab somebody summarize median nerve examination at the hand. So you always conclude with feeling the pulses. Yeah? Median and ulnar pulses. Somebody conclude. What do you see in you? What do you see in feel? What do you see in move? And special test. Something like what Dayang did, but a little bit more. Okay, Dayang, you can choose lah somebody. Guys pun tak boleh instant. Just tell us again, recap. Tapi dia nak wish dengan satu berikut tu. Dia choose nanti.
Amira Basit.
Okay. Just tell us what did Dayang do just now. Okay, so first from look in the median nerve compression, carpal tunnel. In a very advanced carpal tunnel, you will have inner muscle wasting. The skin usually sting. So again, you skin, muscle and bones and joints. Okay. So there will be thinner muscle wasting. Sometimes there will be a scar. It can be an incomplete release. We had one patient for last time exam. Patient dah buat carpal tunnel release, but symptoms persisted. This is a difficult case for short case, but patient came anyways for exam. The candidates passed. So if you get a difficult case for exam, most of the time you pass. If you get an easy case, difficult to pass. Okay. So yes, first there is thinner muscle wasting. Okay, let's talk about median nerve lah. Thinner muscle wasting, no cervical scars, no other deformities, no stigmata of rheumatoid arthritis. Because you want to rule out something else. Okay. So you examine the palm and then you examine the dorsal. No dilated veins, no other deformities noted. Finish. Look. Feel. You feel what? Temperature. There's no changes in the temperature. There's no bony prominence or tenderness or bony prominence. None. Next, you do range of motion.
Range of motion.
You are especially flex. Extend. Remember, trigger finger, patient cannot extend it. Okay. Yes, finger cascade as well. Know what's finger cascade? Yeah? If you don't know, don't say yes. Okay, now finish. Provocative test for median nerve ataupun specific for median nerve. What do you do? Thinner sign, okay. Okay. Sebelum tu yang Dayang buat first. Makcik cuba tunjukkan jari ke sini PPP first. And your opponent. Then you have FDS and you have DPS. Okay. And then you do thinner sign. Then you do provocative test. There are 3 provocative tests for the couple tunnel. The other provocative tests are proximal. Now, what are these provocative tests? Supinated hand, resisted flexion. And then extended hand, resisted pronation. This is just to show that the thing is proximal to the carpal tunnel lah, for later TB syndrome. And also your Lermite test lah, reproduction of your radiculopathy. And you conclude examination by?
Pass.
Okay, so thank you for the summary. Yeah? Alright, okay. Anybody has any doubt on median nerve examination? Ada? Tak ada? Okay, we move on to ulnar nerve. Okay? Boleh? So ulnar nerve examination, there are 7 things you should look at. So there are 5 things actually you should look at in median nerve examination. We covered all these 5 in our examination. The ulnar nerve, there are 7 things. I won't tell you what's the 7 things. We'll just go through the steps again. So again, Dayang and Sarina, simple examination. So remember, ulnar nerve, very typical. You get a claw hand. Claw can be a high claw or a low claw. Can be a complete claw or a partial claw. It is all this one. You have to know what's the difference. So a high ulnar claw is known as ulnar paradox. Why is it called ulnar paradox? Yes, paradox means berbeza lah, the opposite. Paradoxically, a high lesion we expect a severe deformity, but it is not. So a claw which is less is high lah. A claw which is very severe is low. Why? In a high lesion, the FDS and lumbricals, the ulnar lumbricals, are spared. So the claw is less obvious. In a low lesion, it is affected, so it becomes very obvious. Okay. Boleh? Allah paradox will ask you for example. So on examination, let's make this Easy for Dayang, right? On general examination, is a comfortable looking makcik who has no, who is alert, comfortable. There are no assistive or orthotics by your side. What are orthotics for the hand that you often see? You can see carpal tunnel spleen, you can see a wrist drop spleen, you can see an arm spleen. You have mentioned it lah, upper limb, lower limb tadi, knee brace, fractures, walking aids. So on examination, this is a comfortable looking lady. She is of middle age to elderly age group. There are no orthotics or assistive devices by his side. On examination of the hand, there is no obvious deformity. There is no obvious claw of the hand bilaterally. We focus on Anna. There is no wasting or wasting of the interossei or guttering of the fingers. So in guttering, you will have our fingers here. Memang dia macam lepuk sangat lah. This shows wasting of the interosseous muscles, small muscles of the hand. Very typical finding in ulnar nerve palsy. So otherwise, there is no surgical scars, no other deformities for the finish when you feel for temperature. There is no changes in temperature, no bony prominence as well. Sometimes patient has a hardware here, dia ada implant kat sini. So you have to feel lah, dia sakit kat situ, then you see lah, there is a prominent hardware fell over the ulnar aspect of the forearm. Don't have to mention what is probably a plate or a screw. So you can get patients like this. We have got patients like this coming with symptoms of compression neuropathy. So look, habis, feel habis, temperature tenderness, range of motion lah, finger kat sikit lagi. So if it's an ulnar claw, let's say patient is an ulnar claw lah, there will be sensory deficit over there, 1.5 ulnar finger, number one. FDS, FDP is probably weak that side. What else specific about ulnar claw? Okay. Sensation to the dorso-ulnar surface is spared in a high lesion, spared in a low lesion. When the ulnar nerve is affected here, the sensation is given more proximal to this, it's spared. So sensation is intact over dorsal area. The palmar area memang you have 1.5 deficit lah. So this is a differentiating point between your low lesion and your high lesion. Besides your ulnar paradox. Boleh? Are you all clear on it? So how to differentiate a low lesion and high lesion? Number one is ulnar paradox. You have to describe what's an ulnar paradox. Number two is sensation. Sensation to the dorso-ulnar surface is spared. So low lesion to be affected in the high lesion. Yeah. And again, the paradox will describe like point is severe, less severe. Yeah? And then what else about your ulnar nerve? Okay, ulnar nerve special test is your Froman's test. Always bring a paper with you, ask patients to do. Why? Froman's test was first described by Dr. Froman while he was taking a trade. He noticed one of the patient baca paper, tapi dia flex. So if you able to adductor polysis is supplied by your ulnar nerve. If ulnar nerve is deficient, the patient cannot do this. He will compensate by flexing. It becomes flexor polysis pula. So dia akan tipu macam tu lah. So usually when do this, you can tarik the paper easily. So when the paper is like this, susah nak tarik. When the paper is like this, it's easy to pull. You all understand this? This is the Froman's test. Another test is the Wartenberg's test. There is Wartenberg's sign, there's Wartenberg's test. It just show failure of adduction lah. You ask patient to keras tangan macam ni, tolak. So if they have an ulnar nerve deficit on the left hand, tangan ni akan masuk dalam lagi lah. This adduction is weak. They call it Wartenberg's test lah. You can say adduction is reduced on the affected hand. Or you can mention Wartenberg's test. If I was the examiner, I'll be impressed. Yeah? So Froman's test, Wartenberg's test.
Okay.
That's all. And finally, your pulses. Settle lah. Okay? Boleh? Can somebody summarize for me, Alana? Let's ask Amin. Can you summarize?
Yeah, first from the inspection, there is hypotenuse muscle spleen, there is ulnar claw.
Yes.
In high lesion, there is ulnar paradox, which is plus claw.
Also guttering of the interosseous, you have to mention this. Guttering is seen on the dorsal aspect. Okay, and surgical scars if there is any. Skin, muscles, bones and joints. Alright, look at this. Then feel.
Feel for the temperature, for the tenderness.
So when can you get temperature deficit in the hand? Biasa tangan mana ada temperature deficit? Kalau kau lah patient duduk atas bantal dia tengah sejuk, sejukkan patient masuk untuk exam kan, suddenly you feel both tadi. So temperature can be increased in an insensate hand. You can get a charcoal hand or very often it's brachial plexus neuropathy. Patient has brachial plexus, the hands will be congested. Here, temperature is very important. But for you all, temperature is important because you want to complete your examination. Temperature and tenderness. Yeah? Okay. And your special test?
Pada special test
First, sensory deficit lah. Sensory deficit where?
over the first,
Over the first.
half of the ulna.
Okay, ulna 1.5 fingers. Yeah. So you don't call this biodermatomy, you just say ulna 1.5. Median nerve, you just say median 3.5. Circle that. Okay. And then what about the dorsal ulnar something?
Ada
If it's a low lesion here, okay, so median nerve tadi, commonest median nerve compression neuropathy is your carpal tunnel syndrome. Coronary artery cervical rare. Kalau ulnar nerve pula, commonest is your cubital tunnel syndrome. So most of the time you get patient with less clawing, ulnar paradox, because it's a high lesion. So fracture of the hoop of Hamid or a pathology in Guyon's canal can give you ulnar nerve, low ulnar nerve lesion. Remember this, yeah? So ulnar nerve is opposite of median nerve. Commonest is cubital tunnel. So sometimes patient can have a scar here, can have a spur, can have gouty tophi here, also can give you ulnar nerve lesion. Okay? Look, feel, move, special test. Sensory deficit, 1, 2.
the muscle weakness.
Muscle weakness, okay, FDS, FDP, alright. So adduction will be weak lah, your Wattenberg's test or Wattenberg's test. Some more? Yes, from those tests. Okay, and you complete your examination by? So in exam, sometimes you are not lucky. When you are not lucky, you get a patient who has very vague symptoms. Can be median nerve, ulnar nerve, radial nerve is rare lah, but you can get lah. So if you're not sure, you just strictly stick